For our last session today, as for those who've been to NMTRC meetings before, we always like to have a kind of interactive discussion about a topic that's come up quite a bit in the last year or so. And one that we've been hearing a lot about recently is really patient-centered care. So we brought together a group of experts. We get questions a lot from local oncologists whether phase 1 trials are appropriate for patients who are non-curative, end of life, whatever we want to call it. Are we thinking about palliative care? Are we thinking about patient-centered care? Really, we want to provide the best care we can for all our patients. We want to make all the oncologists that are sending us patients feel very comfortable that we are thinking about every aspect of the patient's care. And so we brought together a group of experts who really think about this a lot. I'm going to go through the panel. So Dawn Burgess is from Superbub Superheroes, a parent foundation. She's also on the NMTRC Parent Advisory Board, helps us as we are making our decisions, and has gone through this herself with her son Brayden. And then Dave Dickens is one of my partners at Helen DeVos Children's Hospital. He is also the medical director of the hospice program in Michigan, and thinks about palliative care for all of our patients in Michigan. And then Don Eslin, as you all know Don Eslin, is a pediatric oncologist here, involved in the NMTRC studies. And then Annabeth Goss is a parent who's actually helped me to think a lot about patient-centered care, has explored naturopathic medicine and kind of holistic type care for her daughter, and is kind of walking this road right now. And then next, we have Blaine Pitts, who is the palliative care specialist here at Arnold Palmer Children's Hospital and works with Dawn. And then we have Dan Rubin, who is a naturopathic physician out in Phoenix, Arizona. And we've been consulting with him about one of our patients and discussing kind of bringing the two worlds together. And then we have Deborah Schiff, who's a pediatric oncologist in San Diego at Rady Children's Hospital, and medical director there of their Hem/Onc supportive care program. And so we're going to give each of you guys 5 minutes to kind of talk about your experience and thoughts. 5 minutes? Yeah.
Okay, so I think in the interest of time, I'm going to be really short because one, it's questionable whether or not I'm an expert. And two, I don't have a whole lot really to say. I think discussion is the more important thing. But I think one of the reasons I'm sitting here is because for so many of us parents, the time that the palliative care aspect is introduced is such that it presents difficulties for us because one, the timing of it sort of feels to parents like it's being suggested that we give up. And aside from watching the horror of watching your child suffer, that's about the most awful thing parents can hear is you need to give up now. Nobody wants to give up on their child. And so I think for me, I probably represent, and 3 of the physicians that treated our son are actually here, so you can probably tell me if I represent the typical parent. I think that we do in that my response to those discussions about palliative care, that to me equaled hospice, equaled giving up, your child's going to die. And that's a horrible conversation. No parent should ever have to have that conversation. And because to me that's what that meant, I think my response was probably the typical parent response. Oh, and here comes my IT hubby that's going to tell me what I'm doing wrong. Because he can't stand it when microphones buzz. Awesome, thanks, babe. Well, that lightened the mood a little bit, right? Because this really is a difficult subject to talk about. I think my response to that was what many parents' response was. Whoa, back up. I am not ready for this conversation yet. I don't want to look at this issue. And really, we have to. Almost everything that we do, whether it's during upfront treatment, whether it's during a relapse treatment, those treatments almost always affect our kids. They impact our kids' quality of life. And so this is something that it's important for us to, it really should be talked about from day one. But obviously, to all parents, this is something that's important. And while it's a difficult conversation to have, we have to have it, because not only do we want our kids to survive, but we want them to survive with the least amount of impact on their quality of life. And I mean, that's why we're all here.
Thanks, Dawn. As we talked to panel about what we were going to say, I took on the task of trying to define palliative care, because I think that terminology does throw people off when you talk about introducing something, and that something shouldn't be hospice, because that's an impregnated term that means a lot to different people. So in order to figure out what that means, I looked it up because I wasn't quite sure how to define it myself. And it was interesting. The word was coined in the 1970s by a Montreal surgical oncologist who was trying to look for a word that worked well in English and French. So he went to Latin. And the problem he was trying to solve was that hospice care was really external to the hospital system, and the need for that type of care was internal to the hospital system. So he's looking for a bridging kind of a word. And in Latin, palliare or palio or palliavi or palliatus, whatever way you want to say it, it actually means to cloak or to cover up. It doesn't mean to alleviate symptoms. It's actually to cover. And I think he was intending on that meaning covering symptoms. But I think in modern language, that term has been adopted into a different type of a covering up, where the need for the discussion is really an end-of-life care discussion. And the palliative care systems offer improvement in quality of life and reduction in symptoms, but the type of discussion that nobody wants to have, and parents don't want to hear, and doctors don't want to give, is really an end-of-life care hospice discussion. So I came here because as we start to enroll patients onto neuroblastoma studies, it's magnifying a problem that we've seen in other patients on a less frequent basis, which is how do we have the conversation, start the conversation at an early enough time point where if somebody does start to decline, we know how to control the symptoms and we can improve quality of life before a child hits a brink of death situation.
And I'm not going to spend a lot of time talking because we really do need to get to stuff, but as the oncologist, primary oncologist on the list, really this all came about, as Dawn said, we were talking early on as what kind of a panel discussion to have, and someone first brought up palliative care. But over several months, we really broadened it out to, we really ought to be talking about all the care that we want to provide for children in early phase studies. And so it's, from an oncology standpoint, how do we introduce that, when do we introduce it, and how to get that discussion going with families so that it's not such a scary process to talk about.
Sorry to put my daughter's picture up during your little introduction there. My name is Annabeth Goss, and I am the mother of Abigail Goss. She's 3 years old. These pictures were taken in January and February of this year. I'm honored to be part of this panel, and I hope anything I say won't be too controversial or misunderstood, but taken in the spirit that it's spoken. My daughter was diagnosed in January of 2011 with stage 4 neuroblastoma, and rather than give a detailed account of all the treatment she's gone through, which would sound very familiar to all of you, I just wanted to touch on three issues that have been a very strong thread woven throughout our entire journey. The next slide is a picture of some of the doctors we've worked with, illustrated by my 11-year-old son. And it's, there we go. Honestly, this is an exaggeration, but at times it has felt very accurate. Within 4 weeks of Abigail's original diagnosis, her oncologist at the time was contemplating using Child Protective Services against our family. We didn't know this until several months later. We were trying a complementary therapy and asked to wait on treatment for 12 more days until we could scan and see how it was working. And he then said if we didn't come in for treatment right away, he would report us to CPS. This was one example of many during that induction time of the nightmare that we went through trying to be a part of our daughter's plan. Being bullied or threatened into treatment is rarely the right reason to ever get treatment, and this was our first real encounter with paternalism in the medical world. Paternalism is the interference of a state or an individual with another person against their will, and defended or motivated by a claim that the person interfered with will be better off or protected from harm. Volumes have been written about this issue, and rather than go into detail and break it down here, I just wanted to say that there is a great and deep need for parents and doctors to be able to communicate and work together without intimidation or using the law as their muscle to get their way. The rate with which cancer is occurring and the dismal success rate or failure rate, if you want to call it that, of some types of cancer is obvious to many that the standard methods of chemo, surgery, and radiation alone are not the most successful way to treat cancer and subsequent treatment. It's terribly saddening to me for any doctor to say their way is the absolute best way to cure cancer, because no doctor has been trained in all of the ways to cure cancer, and cancer varies from person to person. Outside the Van Andel Institute is a bench engraved with a quote from David Van Andel, the founding chairman and CEO, that says, "It's important that we as a community continue to act on our dreams, take smart risks, and dare to challenge conventional thinking." Even if integrative or complementary or alternative medicine isn't something that you personally agree with, a modicum of humility in discussions talking about it would serve everyone very well. During one phase of Abigail's treatment, we were working with a very skilled, educated, intelligent doctor, but there were a couple occurrences that left us puzzled. During one visit, I had 4 questions about Abigail's health that I wanted to discuss with him, and I asked the first question, which happened to be about vitamin D, and his response was immediately very defensive and factually incorrect. And as I asked my next 3 questions, I just had a sinking feeling as my questions were shut down, and I was treated as silly and inconsequential, and there was just, it was condescending, and his answers were arrogant, and it was a very bad feeling. These questions were important to us as parents, and so having those bad feelings, trying to get answers to your child's health wasn't compatible. In addition to that scenario, because he didn't understand or trust cancer treatments that he was not familiar with, he wasn't open to discussing them as part of Abigail's treatment. We left this doctor eventually because he wasn't open to discussion, he wasn't open to challenge. The study felt more important than our child, and we were just simply the parents, and he was the doctor. Ultimately, Abigail's care is more important than any doctor-parent conflict, and we would have stayed if it was necessary for her, but she reached the limit of anything he could offer, so we left. The doctor had said at one point in our communication that parents are an integral part of the patient care, but his actions were completely opposite his words, and that was a very difficult thing. Standard care is a great place to start and possibly a good plan to follow for the duration, but if standard care is so rigidly adhered to that it can't be custom tailored for individual needs, then in my humble opinion, standard care is failed care. Then our most recent, one more? Oh, now it's gonna kick me out. Can I go back? Okay. Technologically challenged here. I only clicked it once. There we go. Oh, okay. Well, I'll just start talking, and if it catches up with me, great. Our most recent inpatient stay was an unfortunate but very clear picture of how pride can damage the healing process. Abigail had a slight neutropenic fever that landed her inpatient, and we know the process and want her safety more than anyone, so we weren't arguing with that. After several discussions with the resident, who jokingly claimed that she wasn't very high up on the totem pole and couldn't make any final decisions, we got to speak with the attending physician about the amount of antibiotics that Abigail was receiving. Once this doctor had made up her mind and given her answer, there was no discussion thereafter, and even up until that point where she made up her mind, there was no discussion prior to that either. Even simple things like asking for Abigail to be unhooked throughout the entire day instead of receiving 10 cc per hour to keep the vein open was met with resistance. Really simple things that shouldn't have been very, very big deals. And before any physicians start worrying that we were doing anything to harm Abigail, these are very insignificant issues, but it was a case of ego. So basically, if there's anything I could leave or add to this panel, is that humble doctors are more effective. Humble doctors heal better than prideful doctors, better than cutting edge technologies, and far better than paternalism. Humility keeps doors and hearts open, and it enhances opportunities for growth and enhancement. It's one of my greatest hopes that educated, committed parents will be allowed to be a welcomed part of their child's treatment, even the final say if necessary, to make it truly patient-centered care instead of study care. And we are very grateful for all of the humble, dedicated, honest doctors who give so much of their time to helping heal our children.
Good afternoon. Well, Dr. Dickens already stole my idea of telling you the derivative of palliative care.
I thought we talked about this.
But the only thing I'll kind of lift up is 13 years ago, the American Academy of Pediatrics released its first policy statement on pediatric palliative care and revealed the kind of the definition. And the American Academy of Pediatrics, the Institute of Medicine, CMS, as well as the World Health Organization all agree that pediatric palliative care should begin at the time of diagnosis for a child that has a chronic, complex, life-threatening condition.
Thank you. I'm Dan Rubin. I'm a naturopathic doctor here from Arizona. I'm curious, since we don't have licensure reciprocity in all 50 states, I'm curious how many people are either familiar with naturopathic medicine or who have interacted with naturopaths. So very few, about 3 hands, 4 hands, 5. Okay, so maybe about 5%. I'm actually a naturopathic oncologist, and the reason I can say that is because in 2004, we started an initiative to separate the naturopathic doctors who wanted to specialize in oncology, since it was such a burgeoning field and people were simply coming to us for that reason. And so I was the founding president of that and became one of the first board-certified naturopathic oncologists. This is my 16th year of practice, and it's only been a few years that I ventured into the world of pediatrics. It was terrifying for me, and now it's not. Now I welcome it, and I enjoy it, and I really enjoy the energy that the children bring. Parents are becoming more educated and are becoming much more advocates for their kids, I see, since I began practicing. Sort of looking at it now as parents being the CEO and the physicians sort of being expert board members on their board. And so I really agree with what Annabeth was saying. I was asked to talk about how I interact with general medicine or general oncology, and sort of what would be the top 5 things that I would maybe give to a patient that's undergoing conventional treatment. Our practice in Scottsdale is mostly integrative, so we don't really refer to it as complementary. We certainly don't refer to it as alternative, unless, of course, somebody doesn't have an alternative, then it's just naturopathic oncology. It's not alternative anyhow. We have very few patients that are treating it as alternative medicine and choosing to do that other than conventional medicine. We have expertise in helping maintain quality of life through treatment, whether it be reduction in fatigue, maintenance in blood counts, keeping them on the playing field, keeping them free of colds and flus, or helping to get them back into the treatment chair if they do get sick, lessening treatment holidays or need for sort of treatment, lengthening of treatment intervals. But I'd say one of the chief roles of the naturopathic doctors from a medical perspective is to approach nutrition and the GI. So whether it be helping people improve their appetite or find things to eat, reducing nausea, constipation, and doing it through drugless means or through naturopathic means. Not that we don't treat our treatments as medicines, and we prescribe them and we use them as medicines, but and even though I do have a DEA number and a license to prescribe in the state of Arizona, which is unlike many other states where we're licensed, we still prefer doing it the naturopathic way. Parents oftentimes come to me and say, I don't know what to feed my children. What do I feed them? And so although we might not give them recipes, we're not really nutritionists, but we will figure out ways to get sort of nutrients into the children to keep their nutrition up, teach them about quality of food, help them figure out creative ways to prepare the food, whether it be just pulverizing them with a NutriBullet or a Vitamix, or teaching them about juicing if they have questions about that. And certainly when we want to use nutritional supplements and nutraceuticals, ways to disguise those too in food. Some of the top 5 things that I brought to the table with my patients, I was thinking about helping to reduce cardiac damage. So we've used a lot of coenzyme Q10, which I'm sure a lot of you are familiar with. Really, there is data showing that it helps to reduce or prevent cardiac damage from anthracyclines. Good data. It's very interesting when you actually look at the mechanism of how doxorubicin, for instance, can create cardiac toxicity. I mean, simply put, it's that the doxorubicin forms an aglycone, and that doxorubicin aglycone has gained, because of its special chemical structure, can gain entrance into the outer layer of the mitochondria in the cardiac myocytes, and it actually replaces coenzyme Q10 in the electron transport chain. And so the mechanism of toxicity is that of oxidation. A free radical is formed when an electron is given to doxorubicin aglycone, where it should be coenzyme Q10 passing the electron down in the chain trying to make energy. And by replacing children's coenzyme Q10 and measuring their levels, we can effectively prevent. We also tend to give a lot of L-glutamine during active treatment. L-glutamine is an amino acid. There's some data on it, and reduction of neuropathy following taxanes. Really helps. There's also data on it in preventing post-surgical infection and increasing healing time. Active kids need glutamine. We're very careful with it sort of in the post-treatment phase, or if there's a long duration of no treatment. Glutamine, you have to watch out. That's another issue too with nutritional supplements, is just because it's natural doesn't mean that it's effective or good or beneficial. And we vet a lot for our patients and their parents. And then another thing that we have to think about too is get a lot of people coming in on protocols already, so you have to tell your patients that an internet plus a credit card can be a problem. And then there's also the story that I always talk about, is the 4 o'clock after school health food store clerk, which is when the parent comes in and says, my daughter has cancer, what's good for them? And then they're giving her immune mushrooms or something like that and boosting the immune system, and somebody may have a cancer of the immune system anyhow. So there's certain pitfalls. I think in the interest of time, I'll keep it at just those 3 items, and if there's any questions about it, I'll be up here. Thank you.
Hi, I'm Debbie Schiff. I'm honored to be invited to be on this panel, and I'm happy to be here with my palliative care hat instead of my pediatric oncology hat. I do have a short PowerPoint, and so I'm the medical director of what we call our supportive care program. We tend not to use the term palliative care to avoid freaking people out. Typically, when we have a new patient with a pediatric cancer, treatment begins with aggressive curative therapy, but with refractory disease or recurrent disease, sometimes the goals of care shift to palliation, where the goal is to control disease, to prevent spread of disease, and to aggressively treat the symptoms. This is the top slide. Is the top figure is what's the old-fashioned or traditional model of care was, where initially you start with aggressive curative care, and then when everything fails, you transition quite rapidly to hospice or end-of-life care. But the model that we use at Rady Children's Hospital in San Diego is an integrated model, where supportive care or palliative care is offered at the beginning, and we like to tell the families we'll aggressively treat your symptoms as well as the disease. And this is just an explanation of the key components of supportive care and end-of-life care. One of the most important aspects is treatment of the pain and symptom control, and I think most physicians and oncologists feel comfortable treating symptoms, but some are less comfortable with the other components, facilitating communication, helping with decision making, and coordinating other aspects of care, spiritual, psychosocial support as well. And oops, I hope I didn't miss anything. Yeah, that's good. In 2005, we were very fortunate to receive an endowment from the Peckham family, which allowed us to start our palliative care supportive care program. That's part of our hematology oncology division, and it's not a consult. So the Heart and Soul is our supportive care nurse coordinator, Joanne Auger. We were fortunate in that at the same time, that same year, we also received a nice endowment for an integrative medicine program as well. So that's often been her foot in the door. She'll meet the families and offer massage, biofeedback, art therapy, aromatherapy, just to, and say to the families, we're going to aggressively treat your symptoms. Whoops. And we've been, we have a wonderful pain service that we work very closely with, and our model allows us to offer both curative and supportive care at the same time, palliative care at the same time. So one of the tools that our nurse coordinator uses is the decision-making tool. She is present at almost all of the decision-making conferences when a diagnosis is given, to discuss a progression of disease or a recurrence. Always before a transplant, she'll be there when goals of care are changing, and she takes notes and puts together this decision-making tool, that's a written document that she gives to the families. The medical indicators would be the options that have been offered to the family, describing both the risks and the benefits of each option. She summarizes nicely the patient preferences and the family preferences, the quality of life at that time of that patient, and then any psychosocial aspects of the family that could play a role in decision making. Thanks. And this is just the document that she completes. We call it a 4-square, and as you can see, there's the possible options that have been offered, patient preferences, quality of life, and any psychosocial or contextual issues. This is a tool that we use to assess quality of life of our patients who are on the supportive care service. It's called the Edmonton Quality of Life tool, and you can see the symptoms are listed. There's a number from 0 to 10, where 0 would be absence of symptoms, 10 the worst possible imagined symptoms. And it's a nice tool in that the patient can fill it out, the parent can fill it out, or the medical staff can fill it out. So one of the reasons I was asked to speak was to kind of suggest some possible palliative care outcomes that could be included in the phase 1 studies, and I was really pleased to see that already quality of life outcomes are included in a number of the phase 1 studies here. Another possible outcome would be to include decision-making support. Either a medical staff person could complete the decision-making tool every time somebody considers enrolling or enrolls on a study, or something that I think might even be nicer would be to have the family themselves complete some kind of surrogate decision-making tool, sort of describe their child as a person, what's important to their child, what options have been offered to them, and describe the support system that they have. And with that, I will end. Thank you.